It says that you are recording now. I can see that.
So there you go. And you are the host. So you are all set.
Okay.
Sorry.
Okay. Well, then I will go ahead and get started. Can everybody hear me okay? Okay, good. Okay, well, good afternoon, everyone. Thank you so much for joining me. Today, we're going to be talking about Hospice 101. My name is Lindsey Thompson. I am the RN Director of Business Development for Generations Hospice. We are a local hospice company that has been servicing Fond du Lac and the surrounding areas for almost 11 years now, and I've been blessed to be with Generations for almost 5. I am always really excited when I get the opportunity to work with our community senior center. Sarah and Kathy have always been very kind to me, so I really appreciate them allowing me to do this today. I especially really like to talk about hospice with anybody that I get a chance to, because there's so much about hospice that is already kind of preconceived for everyone. You know, it has like such a negative stigma. And a lot of the times when I'm done talking about hospice and what hospice is today, a lot of people are usually generally surprised about what it is now. They usually say, man, I had no idea. I really thought it was different, or I'm surprised to hear about everything that's included with the hospice benefit. And obviously, too, I really like to educate people before they need that service. You know, you or a loved one may not need it right now, but it's such a wonderful resource to have, because generally when you are in a situation where they're talking about hospice, it can be very overwhelming, you know, and a lot of different things might be going through your head. And it's kind of nice to already have a little bit of a background or a little bit of a familiarity with what hospice is, because it can be kind of a relief that you at least know something, and that you maybe know someone to talk to, or at least have an idea of what that will mean for you or a loved one. So I'll start. There will be a PowerPoint available to you. I believe they'll send it out or make it available. So to start, hospice is still considered end of life care. Okay. You know, so it does usually involve someone who does have a diagnosis that will likely will cause them to pass away. Now, when you think of hospice, though, I don't necessarily, everyone seems to think that it's going to happen that next day or that week. People seem to assimilate hospice with the very end of life. And while sometimes that could be the case, depending on the diagnosis, most of the time we really encourage people to reach out for hospice a lot sooner. What hospice essentially is there to do for you is to manage your end of life symptoms so that you can have the best quality of life until the end of life. And that is better served when we have a few weeks to months to get to know you as a patient, to be able to treat you the way that you wanted to be treated during that time. So the dying process, you know, begins a lot sooner than people think. And it's not always something that's really easy to define. You know, we think of things like cancer or, you know, end stage heart failures, and it's easier to kind of see that picture of, you know, end of life. But sometimes it's just a combination of a couple of different, you know, diagnoses. So maybe there's some heart failure going on, maybe there's some respiratory failure, or maybe it's just a natural aging process that is causing someone to slowly decline. You know, it doesn't always have to be, or sometimes it's not always right there where you can say, this is, you know, going to be an end of life process, but you know that maybe something is changing. And that's where we would encourage people to reach out and maybe learn more about if hospice is the right choice. One of the things that people don't know is that hospice is actually a Medicare benefit, and it's kind of its own benefit. I would say about 99% of the individuals that we bring onto hospice do qualify for Medicare. And if you qualify for Medicare, it's actually a free benefit, which means that there is never a cost for anything that hospice provides. And that is from our visits to equipment to anything that hospice covers and brings is covered 100%. I really like to talk about that because I think we can all agree that healthcare is very expensive. I mean, a lot of the things in healthcare are expensive. So it's a lot of the times that's the biggest barrier to people reaching out for more service because they think that they can't afford it, or they think it's going to cost, way too much. So knowing that it is a covered benefit is sometimes, again, can take down that barrier for you to reach out. There are also coverage options under Medicaid. We have picked up individuals off of Medicaid. And on a more rare circumstance, there might be coverage under a private insurance, but most of the time we're servicing individuals that do qualify for Medicare. One thing too that I know sometimes has come up in the past, which is not true, is that there is no network for Medicare hospice, meaning that if an agency tells you, well, we're in your network and this agency isn't, that's kind of false. Every hospice agency is under the Medicare network. I've never heard of anybody not being able to do a Medicare hospice. So just know that you have that freedom of choice with whatever provider you want to use. That's something really key, because a lot of people don't realize that there's more than one provider. And sometimes it's really great for you as a consumer to check out the different services that are available and even interview them or ask for a consult to see maybe what the best fit is for you personally, or your loved one, or whoever is needing hospice service. How a person is determined to be eligible for hospice is pretty much dictated by Medicare. So another thing, it used to be a lot more broad. We used to be able to provide services for things like failure to thrive, which is a real general kind of diagnosis, or things like debility, again, a very kind of general diagnosis. And as a lot of government programs recently, it's really kind of started restricting, and they're becoming a lot more specific. So it really needs to be a very specific diagnosis, like end stage heart failure, or one of the things that we use sometimes is protein calorie malnutrition, because maybe someone is all of a sudden losing a lot of weight and they're not meaning to, and maybe their appetite is going downhill, and we find that that be a person who is likely to need hospice at this point because they're losing weight so fast. So it's not always black and white. Sometimes we have to find it, but it is something that we would have to find eligible in order to provide service for. So as much as we would just love to provide services to everyone, there is a process that has to be gone through. But don't let that discourage you. If you, by the end of this, if you have, or even down the line, if you feel like this is a service that could be useful, or that you or your loved one needs this service, reach out and ask to see if you can have a consult, or an evaluation, or talk to your doctor about it, because there is no harm to do just the general evaluation. I personally have done a lot of evaluations myself, and sometimes if they're not eligible, at least I can give them a good guideline as to, okay, what should you watch for, or what are some of the things that maybe would happen that would make that person eligible. So you kind of have a little bit of a, like I said, a guidance. So you're not thinking so overwhelmed or not really sure where to turn. I could tell you, okay, watch for these things, and maybe we could reapproach it in a month or two, whatever the case be. So again, it's all covered. So hospice as a benefit, what it includes, like who is part of your hospice team? Well, the hospice team consists of, first and foremost, your primary physician. So here's another kind of little myth about hospice, is that you don't need to stay in the same kind of network as your primary physician. So I use this example a lot in this area because Agnesian is very popular in this area for primary physicians, or Aurora. So if you have an Aurora doctor or an Agnesian doctor right now, they also have hospice services, but you do not need to necessarily use Agnesian hospice services to keep your Agnesian doctor. Like I said, 99% of the time, your doctor would still continue to follow, even if you're on Generations hospice. So it's just something else that people don't commonly know, that even though you have a physician through this network, you could still use a different service if that one was a better fit for you. So it will include your primary physician. It will also include our medical director. Like, so if you came onto our hospice, it would also include our medical director, who is sort of our doctor. We have not only a primary physician, but we have a co-physician, and we have them in case we have emergency orders. So as you know, your doctor is not always going to be available in their clinics 24 hours a day. So if it's a holiday, a weekend, or an emergency in the middle of the night, we as nurses have access to a physician who can either give us verbal orders or they can get assigned orders so that we can get what we need even in an emergency. So that's why we have them as a wonderful resource. And then they also kind of oversee the big hospice case to make sure that everything is going well with a hospice case. Each person would also have their own RN case manager, so their own nurse that comes and manages their case individually. We have certified nursing assistants that are home health aides. They come and they help with things like bathing, hygiene, or I like to say that little bit of pampering, because they do hair and they'll do some nails, and they kind of add that just extra little care onto service. We also have medical social workers who are master levels at our company, and we have spiritual coordinators or chaplains that are specialized in end of life spiritual journeys. We have volunteer services that we can provide, and now, of course, we're just getting into offering music therapy, and sometimes music therapy can be really beneficial if a person qualifies for that therapy. So it really is quite a big team. And so what happens if you're on hospice is that these individuals would come to see you wherever you are home. So home to some people is an apartment complex. Home might be an assisted living facility. Home might be a nursing home. We can come wherever you call home. The only place that hospice really cannot coexist is a hospital. And part of that is because hospitals obviously specialize in aggressive treatment. And hospice, while we do treatments, we don't do aggressive treatments. And I'll talk about that just a little bit here in a minute. So we would come and we would provide you services at your home. So typically you would see a nurse at least once a week, if not more. So hospice kind of is really fluid. It kind of depends on how the person is doing. So if a person is doing well, maybe once a week is enough. But if you become ill, if you're going through having uncontrolled pain, we can be there as much as every day if we need to manage the person or to make sure that they're comfortable. And sometimes as they're approaching a very near end of life, we usually do make people daily visits just to ensure that the family has the support that they need, that the patient has the support that they need, and that they're not alone, during that process, and that they're comfortable. Obviously, for hospice, comfort is always our number one priority. And the other disciplines can help as much as needed. So the RN is really looking at your health, looking at your symptoms, talking with your doctor to see maybe you need a medication change. Maybe you need a new medication. Or maybe you're having some skin problems now and we need to order treatments and bring supplies to treat a wound. The nurse can do that as well. So that's kind of what their focus is. The home health aide, like I said, helps with bathing and things like that. Our social workers are a really great resource for a lot of people. They can connect you to a lot of other resources. Some of our social workers can help set up Meals on Wheels because they'll connect with the ADRC. Some can help with filling out power of attorney and advanced directive paperwork. We have some that can help with additional planning, like funeral planning, end of life planning. And then, of course, they're there to help with that social aspect of that patient or family. What's really good too, I think, is we're not just there for the patient as a hospice team. We really recognize that the family is a huge part of care. So we're there for the family as well, especially during, to support them during an emotional time if need be. Our chaplains that we have are non-denominational. So like I said, they really focus on whatever that spiritual experience is for the patient and try to help that along or to provide services that fall really more in line with what their spiritual preferences are. And not everybody needs to have, if you don't have to have that chaplain if you choose not to, or if you have your own priest that comes. You don't have to have the social worker if you feel like you don't need that, but they are available to you if you would need them. Same thing with volunteer. Volunteers are really good for folks who maybe have a loved one that's far away, that doesn't get to come as much. Someone who maybe really needs an extra one-on-one time. Our volunteers can help with some games. They can play activities. They can just sit with the patient and talk to them to provide that one-on-one time. I think COVID has taught us how important socialization is. So it was really a blessing that our teams were still able to go into those facilities and really, kind of be the stand-in family for some of these patients and be that connector piece between their family and the loved one, to be kind of, I know for a lot of our families, that gave them a good peace of mind to know that we were still in and kind of acting in their place and being a connector between the two. Like I said, we learned how important that was, during COVID. So those are just some of the things that the hospice team can provide. So visits from, like I said, the visits can range from once a week to daily. We kind of talked about some of the trigger events, other things, going back to what hospice can cover. So not only will it cover all of those visits, but it will also cover what's called durable medical equipment. We refer to it as DME in my world. So let's say that you have a loved one who's coming onto hospice or going home maybe from the hospital onto hospice, and they need equipment. They need a hospital bed. Maybe they need a new wheelchair or a specialized wheelchair. Or maybe they've gotten so weak that they need a mechanical lift, we call those. Well, we would provide that. We can actually order that through our DME company and bring that to you and show you, how to use that equipment so that you can safely care for a loved one at home or, again, wherever they are. If the facility needs that equipment, we can coordinate all that at no cost. I find that that's a huge benefit because, first of all, it's really hard. I mean, imagine, as a family member having to be in charge of all of those things. Where are you going to find equipment? You have to work with insurance to cover it. You need to, get your face-to-faces set up. It's such a huge burden for families. So I really like that the hospice benefit can do that because it takes a big piece of that away, so family can really, just be family and not have to worry about all that small, all those small things that we get to kind of have to worry about, that background stuff. Hospice can also start to cover for medications that are relevant to the diagnosis. So if you came onto hospice with a respiratory disorder, we would cover all the respiratory medications. So Medicare would cover breathing treatments, inhalers, any other medications that were linked to the respiratory disorder, we would cover. Speaking of medications, another myth that I like to get rid of is that hospice comes in and takes away all medication. That is very untrue. I've talked to a lot of people and they think that we get rid of all medications and all we do is comfort medications, which a lot of people realize is morphine and lorazepam. Well, yes, we can use those medications at times, but we don't automatically usually initiate those until they're needed. And for the most part, we keep all the medications that are in place as long as they're medications that are helping your symptoms. There might be some vitamins or some things that maybe aren't really working as well anymore that we may recommend that we, take out. But other than that, we do not stop medications unless you, the patient, or the POA wants those to be stopped. Those are for comfort. They still treat your symptoms, so we will still continue those. Other things that we will use are things like antibiotics. Yes, we do still treat infections. We, of course, are going to, treat your wound infection or treat your UTI. That's part of comfort. So it's a myth that we don't treat, because we do treat. Other things that we can do sometimes is if we have a patient that falls and we think that maybe something's broken, we can actually arrange for mobile x-ray to come wherever they are and take an x-ray to see if we do have a broken bone to see what we can do. Because again, ultimately that goes for comfort. But what we don't do anymore on hospice is we won't send our patients to the hospital to be acutely treated. We become kind of the hospital because we're available 24 hours a day, 7 days a week, 365 days a year. So if we are, if there's an emergency, you would call hospice, and hospice would have a nurse that could come out, in an emergency to assess the situation and have things on hand to hopefully be able to manage whatever's going on. So we don't really send people to the hospital, and we don't send them for procedures and things like that. That's considered aggressive treatment. So that's what we call kind of the hospice mentality. So another indicator that you could be ready for hospice, or your loved one might be ready for hospice, is saying, you know what, I can't be, there's really no more treatment for my condition, and I don't want to pursue any aggressive treatment. I don't want to go to the hospital anymore. Those are kind of indicators, okay, that's time maybe for hospice to come on board, because we can help manage your condition to the best of our ability at your home. So you can stay wherever you call home and be as comfortable as possible. And that's kind of what we really focus on. But I do tell people a lot, as individuals, when you and I are sitting at home, we usually wait until our symptoms are pretty bad before we even go to the hospital. So a lot of people sometimes have some anxiety that they maybe can't go to the hospital anymore. But as a hospice agency, we're coming to watch you every week at least. And so we really do kind of catch those small changes happening long before you would be so bad that you would want to go to the hospital. So I find that that's really not even an issue, that most of the time we are already treating some of your issues before it gets to be so bad that you feel like you need hospitalization. But to sum up along with that, just know that the hospice benefit, if you choose to use hospice or have hospice on board, it's not a contract. So if you sign up for hospice, it's basically just a consent that we can provide care for you or your loved one, whoever the person is that's going to be treated, but it's not a contract. So, if you change your mind, let's say you become very ill and you change your mind and say, you know what, I want to go to the hospital. I don't want to be in hospice. You simply revoke. It's not a hard thing to do. You call and you say, you know what, for whatever reason, this is not a right fit, or I want to go to the hospital, and you revoke from hospice. And it's pretty simple. There is no penalty from hospice. You're not going to get this bill from hospice. It's just nice to know that you can still change your mind, that you have options. You're constantly going to be still in control of your health, which I think is important, because some people feel like, I don't want to be locked into something, and you wouldn't be. Hospice is also a non-exhaustible benefit, which means that as long as you need that care, and you're eligible to get it, it will not run out. So, I have seen people be on hospice for 4 years, because they're still eligible. It's not as common to be on for that long, but I've seen it. I have also seen people graduate from hospice. Actually, we graduate people all the time. So what it means to graduate from hospice is we came on board because maybe a patient was ill and we thought, that they thought maybe this was their decline. And with some care and maybe some medication changes, they bounced back and they became stable and they didn't need us anymore. So we graduated them, and some of them stay graduated for years. Some people maybe need us again in a couple months and we come back on board. But it's nice to know that there's not always the same end result. Sometimes you can graduate. And again, hospice will still be there for you, even if you do graduate. So it's not only a one-time benefit, and it's not something that can run out for you. Like I said, as long as a doctor deems that you're eligible and Medicare sees you're eligible, we can provide that service as long as you need that. Some things that are kind of what we call trigger events. If you're wondering kind of what kind of things would I look for in myself or a loved one that might indicate that I would need hospice, is, things that aren't so black and white, like things that aren't just cancer, or things that aren't just something that's very clear. Sometimes it be things like you're finding yourself, appetite is a big one. you're not eating anymore, you're not hungry anymore, or you're eating and you're still losing weight unintentionally. That's always kind of a red flag. Or let's say you're having more falls, or you're more weak, you're sleeping more, maybe more confused. A lot of the times we see people who might have something like an Alzheimer's dementia, or just a dementia in general, and they do really well, and all of a sudden they decline. They go from being very independent in their own apartment to a memory unit, and they don't know where they are. They might be incontinent now and not walking as well, wheelchair bound all of a sudden. So sometimes I look for those rapid changes, because sometimes that's an indication that something's going on, and maybe we can't pinpoint it, but it still tells us a story that there's some decline going on, and maybe it's time for more care. You know, Something else too that's a common myth is, well, if you're in assisted living, you don't need hospice. And actually, it's even better. If you're in assisted living, you already have a care staff there that's helping you, and we come in and we're kind of like, again, that extra care on top of that. So wherever we are, we're just a bigger part of their team. All kind of for the same. We all have that same goal, and that is to take care of our patient the best that we can, and to connect families and to kind of take away all that burden so that the families can focus on what the most important thing is, and that is being a family, spending the time together as a family, and making memories, still having good conversations, and not worrying about, when am I going to take you to your doctor's appointment? When am I going to take you to the hospital? When am I going to get this med? Where am I going to get this equipment? All of that stuff can just melt away, and you can just be a daughter, a wife, a husband, whatever you are to that patient, or the patient yourself. You don't have to worry that your family has to coordinate all this. So if nothing else, hospice can certainly be just a big relief in a very uncertain time, and offer that reassurance. For bereavement purposes, if we do have a patient, and the patient does pass away, hospice doesn't just stop. A lot of people think that that's it, hospice is over. We actually continue to follow our patients and families, obviously the families, for up to over a year, afterwards, just to make sure that everyone is doing as well as they can be. We can still offer them resources. There have been some cases where we have husbands and wives who, after they lose their spouse, we've continued to actually visit with them in person, because, after being married for 70 years, it's a hard thing to lose a spouse. So sometimes we recognize that they still need our services, and I think for generations, at least, that's something that we take a lot of pride in, because we want you to know that, when you're on our service, you are a part of our family. This is not something that you're just, a number to us. You are a part of our family, and we make sure that we take care of each and every one of you as long as you need to be taken care of, essentially. So, is it an easy conversation? No. As a society, we do not handle death and dying very well, and we don't talk about it a lot. So hospice is still very unknown to a lot of people, because until we need it, we really don't seek out information about hospice. That's why any opportunity that I have, like today, to give you some information so it's not so scary, so that you really know what it's about, I really try to take advantage of that, because again, you might not need it today or tomorrow or even in a year, but somewhere down the line, if you do need it, you'll be able to at least recall some of what I've been able to tell you, and kind of hopefully what that will do for you is take a little bit of burden off you and take away a little bit of fear, so that it's not as scary to talk about. So that's kind of what hospice is. I mean, in a general nutshell. Did anyone have any questions about what we talked about? I think everybody's on mute still, so I don't know if anybody can hear me. I can hear you.
Does anybody have questions?
So I will, what we talked about today, like I said, is in a general PowerPoint, which which Kathy has. On that PowerPoint is also at the very end is my name and my contact number. If anybody were to have any other questions, or even if it's down the line and you want to get a hold of me, please reach out. That's my work cell number, and I'm always welcoming any calls, especially if it's just for, you have questions or anything that I can help you with. Please don't be afraid to reach out to me. Or you can talk directly to the senior center. Those ladies know me very well. And they can track me down too if you're afraid to call me direct.
Most definitely.
Do you think that covered everything, Sarah? I think I got everything okay. Yeah.
I think that was wonderful. And I especially like, when you talked about choices, that's huge. People have choices.
Right.
So often we do go to the doctor and they do refer us to someplace, but always know that you do have that choice to go where you want, or to get a second opinion, or to, like you said, get consults.
Right. Oh yeah, absolutely. That's one thing I was gonna say. Most hospice companies, we are all regulated by Medicare. So there are certain things that are going to be the same. We all have to provide them. So they're going to be the same. But every hospice does have a little bit of a different approach. They might have their own special programs. So yeah, I mean, please, reach out to those hospice, ask for that consult, see what the right fit is. And then if you choose one, and let's say they're just not, I like to say, cutting the mustard, they're not doing what you are looking for, you can transfer. It is very easy to transfer to another agency, and don't be afraid to do that, because the end of life journey, you really only do that one time, so don't accept care that's not good. Don't accept someone that's not answering you promptly, or not coming to see you like they should. If that's the case, you can fire them. you just revoke, and you go with a different hospice agency. So people sometimes are really afraid to do that, but it's your health and it's your care. Don't be afraid if they're not doing what they should be. That's why you have choices. So that's another thing I tell people all the time, and do your homework. I mean, I love to take care of anyone. I think we're a great corporation. I mean, I think we're a great company, a small company. We're very community oriented. But you know what? I encourage everyone to do your research and to reach out to whoever to see who the best fit is. Absolutely.
I've been listening from the shadows, Lindsey, and I just think one of the most important things that you said, and one of the things that Sarah and I mention to people all the time, is these services allow you to go back to being the spouse or the daughter or the family, and you don't have to worry about the meds and the equipment and the appointments. And so many people that we've talked to that have chosen the road of hospice have come back to talk to us afterwards and just said, what a blessing that we were just able to be there, like you said, to make the memories, to spend the time, and all the pressure and stress that goes around with it, was relieved. And hospice is a scary word, the whole concept, and what does it mean, and like you said, all the misperceptions of what it is. But I have never talked with anyone in 18 years of long-term care work or senior, working with seniors. I have never talked to anybody who has regretted the decision to bring on hospice when it was time. And
Right.
usually it's the opposite. People wait way too long,
Right.
and they get admitted in maybe a week or 2 weeks, and it's just the very, very end, and they don't understand that they could have had it for months ahead of time. And so
Yeah.
it's a wonderful service.
I'm glad that you say that, Kathy, because that's true. I mean, but you know what? I get it. People too often, they look at hospice as giving up. And we don't give up on people. We don't give up. There's still quality of life there. There's still symptom management. There's still ways to help a person live what life they do have, and enjoy what they have. And it is scary. And that's why people do wait, because they think, well, we're giving up. Hospice is giving up, and it's not. And the thing too is, when we do get an opportunity to get to know our patients, it helps us to be there for them, because we get to know what they like, what they don't like, what makes them feel comfortable. And, when you're coming in so late, it's hard to catch up and get to know that person, and sometimes that's not a choice. I understand. Sometimes it's something that happens really sudden, but if you can, I mean, it never hurts to reach out sooner than later, because then you have that extra support, even for, yourself as a family member, if you're the one that's reaching out. But I agree. And I think I'll end with something that my executive director actually, it stuck with me because I guess I never thought of it before. And her biggest motto is always, if you take the sick, the SIC, out of hospice, you get hope. And that has impacted me ever since, because I really do believe that what we provide is hope to families, that it's a phase of your life, but it doesn't mean that it's over right then and there. There's so much more to still enjoy.
Thank you.
Thank you very much.
It was very, very good. We appreciate it. And it's always
All
good.
right, well, thank you for being with me, you guys. I hope you have a good rest of your day. Like I said, please, if you need me at all, you let me know. Thank you, Kathy. Thank you, Sarah.
Thank you, Beth. Good to see you,
Thank
Lindsay.
you.
Yeah, you too. Now, do I just end?
You can, otherwise Sarah will reclaim host in the back, and then we will save the presentation and we'll upload it to our YouTube channel, and then we'll also throw it out on social media that it's there for people to watch either again, or people that weren't able to be here now can always go there and
Okay.
just take a listen. So,
Well, then a shout out to anybody who watches me later. Thank you so much for watching, and let me know if you need anything. Mwah.
Bye.
Bye.